Good afternoon. Welcome to the Assembly Committee on Health and Human Services. Will the Secretary please take the roll?
Assemblywoman Gonzalez.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Gray.
Here.
Assemblyman Hafen.
Here.
Assemblyman Hibbets.
Here.
Assemblyman Koenig.
Here.
Assemblywoman Newby.
Here.
Assemblyman Wynn.
Here.
Assemblyman Orentlicher.
Here.
Assemblywoman Taylor.
Present.
Assemblywoman Thomas.
Here.
Chair Peters.
And I am here. Everyone is present. Thank you all so much for being here today on this President's Holiday Monday morning. We have 2 bill hearings on the agenda for today coming from committee members. We will be helping present these bills today, so I will be stepping down for a period of time, and Vice Chair Ornlicker will take over during that hearing. A couple of housekeeping items. As always, please ensure that your electronic devices are silenced. I just perpetually keep mine on silent anymore, you guys, so I don't make the mistake of leaving that on. Members of the public may provide testimony in a variety of ways, all of which are listed on the agenda. You may also submit public comment in writing, either in addition to testifying or in lieu thereof. Written public comment may be submitted before, during, and up to 24 hours after the meeting's adjournment. If you wish to testify in person, please sign in at the table by the door and leave a business card so we can get an accurate record of your name. Agenda items may be taken in different orders than listed. 2 or more agenda items may be combined for consideration. An item may be removed from this agenda, or discussions of an item on the agenda may be delayed at any time. To ensure an orderly flow of discussion, all comments, questions, and responses must go through me. Also, committee members must be recognized before you may speak. Additionally, I ask our presenters on Zoom today to leave your cameras off and microphones muted until it's your turn to present, and I direct questions directly to you. When testifying in person, please turn the microphone on to speak and off to listen. We have other people listening, and we will get feedback if those are not turned on and off properly. With that, we'll move on to our agenda. We have 2 bill hearings this afternoon, and I have allocated equal time for testimony in support, opposition, and neutral after the bill presentation. To be specific, each person providing testimony is allowed a maximum of 2 minutes. Staff will be timing each speaker to ensure everyone is given a fair opportunity to speak. A reminder on providing testimony. Per Assembly Standing Rule 54, a person must state for the record whether they support, oppose, or are neutral on the measure before the committee. As such, support consists of approval of the measure as written or as written along with proposed amendments that have been approved by the sponsor of the measure. Opposition consists of not supporting the measure as written or as revised by an amendment that has not been approved by the sponsor of the measure. And a neutral position on a measure is one in which the person offers particular insight on the measure but expresses no position on the measure. We are going to take these hearings out of order because we have a time crunch today with one of the presenters. We're going to start with AB 138, which I will be moving to the front of the room to present. I'm going to, should I do a recess real quick and then have assembly? I can open it though. Okay, we're going to go ahead and open the hearing on AB 138 and do a little bit of moving of people real quick.
when you're ready to begin, thank you for presenting this bill.
Thank you, Vice Chair Ornlicker and members of the Committee on Health and Human Services. I'm Sarah Peters. I represent Assembly District 24, and I'm happy to be introducing AB 138 to the committee today. AB 138 requires the state plan for Medicaid to include behavioral health integration models such as collaborative care as part of the services covered in the state plan for Nevada Medicaid. So short. The collaborative care model supported by a behavioral health provider acting as a case manager is an effective way to provide integrated and comprehensive care to patients with mental health conditions. This model requires a team-based approach that involves psychiatrists, pediatricians, and primary care physicians working together to provide coordinated care to patients. Today, we have several experts with us to help explain the bill and the impact it will have on Nevadans. On Zoom, we have Dr. Brian Irier, with the High Risk Pregnancy Center in Las Vegas, Dr. Lisa Durrett, child of an adolescent psychiatrist and founder of the Pediatric Access Line, Dr. Karen Esposito, psychiatrist and interim chair of the Department of Clinical Services at Roseman University, Kristen Pendergrass with Shatterproof are all here for any questions related to implementation in other states and technical questions. Here at the table with me is Leah Case, lobbyist for Shatterproof, for a bill walkthrough if desired. I do want to mention that this was an interim committee bill that came out of the 2021-2022 interim and was approved, I believe, unanimously out of committee for BDR introduction this year. And with that, I will let Leah Case go through the bill for you.
Thank you, Madam Chair and members of the committee. I am not the expert on this. I was just here to offer a bill walkthrough after the doctors have their presentation. So I'm actually going to turn it over to Zoom, where Dr. Brian Irier from Las Vegas has taken from 130 to 150 out of his clinical duties to walk us through the collaborative care model. I believe I see the TV changing, so I will turn it over to broadcast and Dr. Irier. Thank you.
Thanks. Can everybody hear me and see me?
Yes, we can.
Great. I'd like to thank you for allowing me to speak today. I'm on call today, so that's why I couldn't be present. And at the time crunch of this, I wanted to make sure I got this in. But to give you a little background on myself, I'm the former president of Society for Maternal Fetal Medicine, the biggest, the most prestigious high-risk pregnancy organization in the U.S. and the world. I'm the current president of Hera Women's Health. I've ran 2 workshops for national organizations in the United States, authored over 25 research articles, and now currently serve as the primary investigator for the PRIME trial, which is the largest preterm birth study in the U.S. in the last 2 decades. What is the collaborative care model? It's something where the healthcare providers use a model to address both the physical and mental needs of a patient in as few visits with a team-based approach. There's a coordinated form of communication between primary care providers and mental health specialists that allow the care to be provided quickly, succinctly, and with expert opinion. It allows primary care providers to do initial assessments and screening, and then refer and stay in communication with more specialized mental health treatment for support. And then these people can coalesce, because they're often in the same environments, do regular check-ins, case conferences, and really coordinate care. Research models have shown this model is much more effective than traditional care, producing better mental health outcomes and reduced overall health costs. If you want to look at it, our current model is one where most patients will talk to their primary care provider about mental health issues, but at that time, the primary health care provider has to decide whether they refer the patient out or they try to treat the patient themselves. If they try to treat the patient themselves, they're usually not the most effective person to be able to do it. If they refer the person out, they have to go to other visits. It's hard to get timely appointments. And this model just doesn't appear to work, and that's exacerbates our current mental health problems. The collaborative care model in contrast to this provides primary care site integration either via telemedicine or people present there with a behavioral care manager who works in collaboration with a psychiatrist on more significant and difficult cases. They utilized organized assessments for analysis and for treatment. And this organized approach overall between the patient, behavioral health care manager, primary care provider, and psychiatric consultant kind of allows more of a one-stop shopping of mental health care and avoids patients from falling through the cracks. And it really helps on social determinants of health, such as problems with transportation, childcare, cost. So much improved. In our office, we have a opioid use disorder clinic where we have a collaborative care model with a behavioral mental health practitioner who has addiction specialty training and a psychiatrist. My office sees these patients during pregnancy and places them on medications that are much more effective and safer for pregnancy than otherwise regularly done. Because of this, we avert things such as neonatal abstinence syndrome, which you can think of simplistically as kind of an addiction of the neonate when born to prolonged opioid exposure. And this makes about a 15-day hospital admission in the NICU for these babies. Because of what we're able to do and do it in our office and put them on safer medications and use behavioral health at those times of visits, we get people that stay in our therapy and get decreased risks of neonatal abstinence syndrome. And we're saving about $45,000 to $55,000 in immediate costs. And that doesn't even count the costs in regards to long-term improvement for neonates into school age and adulthood. But what we'd also like to do is get to maternal mental health, where 1 in 7 people have postpartum depression, 60% of people that have suicides postpartum never saw a mental health provider in the previous month. It's estimated that 20% of all people have mental health disorders during pregnancy, and those are increased in people below the poverty level. There are estimates of treatment. If you treat women during pregnancy with this collaborative care type model, you'll save $32,000 per mother-child pair in the first 5 years of life. Our problem is we can't set up some of these clinics or they're likely to fail over time because almost no commercial insured supports collaborative care billing, and the Medicaid and Medicaid MCOs do not recognize these codes at all. Hence, the model can't grow. It's rather limited. We, for example, are the only practice in Nevada specializing in a collaborative care model. And although we generate cost savings, we cannot bill for the services that we provide effectively. Our office, nonetheless, our partners took the money out of their own pockets, and we've lost about $200,000 per year in our first 2 years, but we did it because it was the right thing to do. After that time, we were able to get federal and state grants, but this is not sustainable for a program. We want to set up a mental health model, but with our other funding, it's very difficult to set this up, and the sheer number of cases would overload our practices. And like I said before, 1 out of 11 people below the poverty level have been stated to have severe depression, and 40 to 60% of those in poverty have some depressive symptoms. It's made it really hard for us to get referrals to services, or these services are just not provided to these patients. Additionally, we have problems with primary care providers to get mental health care contracts because it's a huge hurdle to set up these programs. It's time intensive to do it. Physicians have to try to get separate contracting. Mental health contracting is separate from physical health contracting. So you would have to do time intensive contract negotiation on that. And the physicians will lack the skills in that because they don't usually do mental health contracting. And mental health is usually reimbursed at a lower rate than physical health. And then lastly, there's separate processes of credentialing for behavioral health physicians separately from physical health physicians. And that's also an additional problem. So our request, or my request, is the collaborative care codes be recognized by Medicaid, Medicaid MCOs, and commercial payers, that the payment for these models not require separate contracting, but they're paid under a single contracting price of the main physical health contract. Mental health affects physical health, especially in things such as pregnancy, and the cost savings are dramatic. And then for collaborative care providers, if we could get credentialing performed in the same ways and process for mental health as for physical health providers, that would be a huge help. And I'm sorry to rapidly go through that, but that's all I have to present. I thank you for your time.
Thank you, Doctor. And we have another presenter next is...
Correct, Leah Case for the record. Next up is Dr. Lisa Durrett. I see her there on screen.
Hi, and thank you all for giving me the opportunity to present. It was really neat hearing Dr. Irier's experience in working in this space of collaborative care, and I'm going to talk about a collaborative care model that's existing statewide that, should this bill pass, this is one of the pathways to help sustain this program. Excuse me. So I'm going to talk about our Child Psychiatry Access Program. And so just to lay the land, you all are very aware that children's mental health has become a hot button issue. And the majority of kids with behavioral and mental health problems don't even receive care. And of those who receive care, the vast majority are receiving it in the primary care space. But yet pediatricians, family medicine docs, nurse practitioners often feel that they are lacking the training to treat these mental health problems, and combine that with the fact that we have a national shortage in mental health providers. Whoops. So if you go to Mental Health, America Mental Health National, they do the rankings of the states. And these are rankings that are determined by metrics each state submits to the feds every year. Our state has consistently ranked 51st in children's mental health metrics. And then tied to that, the fact that we have a severe statewide shortage of child psychiatrists. Obviously, you can see up in Washoe County and then down in Clark County, we have child psychiatrists, but we're far behind the national ratio with only 3 per 100,000 versus the national average of 14 per 100,000. And part of why we have these providers up in Washoe and Clark is because both of these regions have training programs. So we're not the only state that's been struggling with this. Back in 2004, Massachusetts pioneered a model, and that's called MCPAP, or the Massachusetts Child Psychiatry Access Project. And it's a unique model that aims to provide child psychiatry support to primary care to enhance their skills, expertise, and knowledge about treating mental health disorders in kids, such that the children are not even getting referred to child psychiatry. Washington came next, and in 2011, the National Network of Child Psychiatry Access Programs was born, and we were the 46th state to join the national network, and we now have our own program. So again, what is a CPAP, or a Child Psychiatry Access Program? It's a physician-dedicated telephonic hotline. Ours, for example, operates from 9 to 5, Monday through Friday. And primary care clinicians, again, it could be a physician's assistant, a nurse practitioner, pediatrician, family medicine, working in any setting, hospital, private practice, like a federally qualified health center, they can all call the line. It's free of charge. And as I'll describe in a minute, it's mental health block grant funded. So they call the line, they speak with a care coordinator who helps triage the call, and they're able to talk to a psychiatrist, again, any day of the week for free. And it's same day telephonic support. We discuss diagnoses, we discuss management, we discuss medication options, we discuss psychotherapy referrals, and our team provides intense care coordination. For about 10% of those consultation calls that we have, we offer a one-time televideo consultation for the patient, again, to help clarify diagnosis and clarify treatment planning for the primary care doctor to pull out. So here's our website for the statewide program. And ours is unique. We are a 3-legged stool. And the legs include, obviously, our medical school down here in Las Vegas, Chicanos por la Causa, and the Center for Community Solutions. I'm the founder of this program. I also started our Child Psychiatry Fellowship in Las Vegas back in 2013. I'm currently the interim chair for psychiatry and behavioral health, and I've been very involved in local advocacy through the Commission on Mental and Behavioral Health. CPLC is an enormous multi-state organization, and our Nevada CPLC chapter is really dedicated to mental health. They are the managers of the homeless courtyard and provide services through there, as well as have 2 rural/frontier certified community behavioral health centers. And then finally, the Center for Community Solutions is our web host and also provides all of the background data. If you're trying to access the program and you do so through a mobile device, you can instantly request a consultation, and it's a HIPAA compliant portal through which consults can be requested. And we have a really simple website that's easy for anyone to access. And most importantly, has one-page infographics and handouts for primary care clinicians to help give them the quick and simple, what do you do with depression? What do you do with anxiety? All of these have hyperlinks to different rating scales, screening tools, and we aim to make this a really educational resource. Since inception, we've provided 563 consultations, and actually this was at the first of the month. There's been more since. And our care coordinators have had over 1,500 encounters. Common diagnoses for which we're taking calls are very different than what I thought starting the program. I assumed it would be a lot of disruptive behavior, ADHD. And although there's a lot of ADHD, it's oftentimes, and you'll see the numbers don't add up to 100, it's usually more than one thing: tics and fleas, depression, and autism spectrum disorder, ASD, ADHD, anxiety, a little bit of everything. One piece of our project, we had gotten IRB, Institutional Review Board approval, to survey primary care clinicians involved with our program before and after the launch of the program, 1 year after the launch. And we discovered that there is a statistically significant improvement in perceptions of access to child psychiatry, as well as a statistically significant improvement in primary care clinicians' comfort in making behavioral health diagnoses, again demonstrating that there's a long-lasting impact of this type of program. So let's talk about sustainability. You know, you heard Dr. Urier describe the fact that these are currently not funded programs. The annual cost of our program is $750,000. Some of that money can be offset through opening up the collaborative care codes. The benefits of the program, not just the cost, are really spilling out to so many patients because there's, first of all, immediate mental health support for primary care clinicians statewide. These clinicians have demonstrated improved comfort in working with mental and behavioral health diagnoses, which means less referrals into an already overburdened system. And it's an improvement in access to care statewide. Our rural and our frontier areas especially now have quick access to child psychiatry. So within the national network, there have been some great examples of sustainable funding, one of which includes a legislative line item for the flat rate of the program, and others include insurance surcharges that would help with the sustainability of the program, as well as finding, as we're talking about today, creative support through Medicaid, including managed Medicaids. There's a lot of resources, more than you probably want to read. And more importantly, I will stay on for a little bit to answer any questions about this model of care. So thank you.
Thank you, Dr. Durrett. And now Dr. Esposito next. Thank you.
Hello, thank you for allowing me to present today. My name is Karen Esposito. I am a psychiatrist as well, and I'm at Roseman University, the interim chair of clinical sciences, as well as the senior executive dean. And I'm going to speak to you a little bit today about the Empowered program at Roseman University. Empowered is a program for pregnant women and postpartum women with substance use disorder, opiate use disorder, or stimulant use disorder, or women who are using opiate or stimulant prescription medications during pregnancy. And we actually work very closely with Dr. Irier's program, share a lot of patients. Empowered provides care management services, therapy services, and as well a coordinated care model with the supervision of a psychiatrist, Dr. Farza Kamiar. So we are very familiar with women who are struggling to find resources, knowing that it's very difficult to get mental health care, and having a collaborative model where we are able to really leverage the psychiatric services and use them to their fullest ability to provide service to the largest number of people. I think what is really critical here. You heard Dr. Durrett mention the shortage of child and adolescent psychiatrists. In general, there is a shortage of psychiatrists in Nevada and nationwide in many, many places in the country. And so being able to use these resources in collaboration with primary care is very powerful and provides a really evidence-based model that's been very supported by the American Psychiatric Association as well. I think I'd also like to add into what both Dr. Irier and Dr. Durrett said in terms of sustainability. Empowered is also currently grant funded, and having the sustainability, the long-term ability to be able to bill for collaborative care models would really help expand the program, give access to more women, and really allow also continuation of care beyond that first year postpartum, where people still need support, still need primary care services, often still need mental health services, whether it's for substance use disorder or for some comorbid psychiatric condition, maybe depression or anxiety. So I will end there, and I'm also available to answer any questions. Thank you.
Thank you, Dr. Esposito. Did you want to wrap things up, Ms. Case?
Thank you, Vice Chair Orentlicker. Leah Case for the record. I was going to offer to do a section-by-section walkthrough on the bill. I think you've heard from the presenters what the bill does. It's exactly what it says on the tin. It is right there in bold print. I did want to clarify that AB 138 does only apply to Medicaid, not to private insurance companies. Medicaid does cover over 50% of the births in our state, however, so it would be hugely beneficial for like the high-risk pregnancy center, that Empowered program, because that's a majority of their patients. And as you heard, it would support our existing workforce, those folks that are, where we're currently understaffed in the mental health and primary care workforce. And it would expand access to mental health care in those primary care settings where folks are most likely to let somebody know that they are struggling. That is all I have, unless you'd like more information on the bill. Otherwise, I'll turn it over to Assemblywoman Peters.
Thank you, Ms. Case. So Ms. Case and I leaned over to each other and were commiserating over our own prenatal and postnatal journeys with lack of collaborative care in most cases, navigating those referrals and organizing your own data to share with doctors is a burden that all of us, I'm sure, have experienced. My own daughter, I've been going around with her trying to get an ADHD referral for her. We got into her physician, got an assessment in, then we're referred to a neuropsychologist, a child neuropsychologist, and I can't get in to see them for another 4 months. It's been a 3-month process for us, and all she needs is a quiet space where she can finish her work in school. If her doctor had been able to refer her in-house to a psychiatrist in their facility, we wouldn't be dealing with that timeline. The collaborative care model is designed to treat a whole person. We all know the healthcare referral dance of obtaining records, getting pre-approval of referrals, etc. This model helps reduce barriers to care and enables providers to work together to meet the needs of their patients. These billing codes we are talking about would cover the cost for providers to coordinate that care for patients, ensuring that the care they are prescribed and receiving is truly meeting the need and iterating the care in some cases in concert with each other rather than siloed, which can result in significant delay in receipt of care. I hope that we have shown you really the benefits of collaborative care and the population in our state that it can touch. I'm at this moment looking forward to hearing the testimony that comes up next, but I hope that we have earned your support for this bill.
Thank you, Chair, and your co-presenters for very helpful information. Do we have questions from members of the committee?
Vice Chair, if I may, Dr. Irier is still available, but he may have to bail here quickly. If there are questions that can be directed to him maybe earlier on, that would be beneficial so he can be here to respond to those questions. Thank you.
Very good, thanks. Assemblywoman Taylor.
Thank you, Mr. Vice Chair. And thank you for the presentation. I had never heard of the collaborative care model. Doctor, thank you for making the time to stay with us. I wanted to go back to something you alluded to in the presentation as I look up at a screen as though you're there. You aren't there. But anyway, okay. You mentioned that there are a few states that have this kind of a model. Sir, would you mind going back to that?
I mean, there are states that have this model. I do not know how many states have this model, but I mean, this was born out of research and a model from University of Washington over a decade ago, and has been utilized in many places around the country. It's just, there's the ability to do these codes because they are in our handbooks of medical codes. It's just that our state Medicaid program does not recognize the codes. And when you do not recognize the codes, it's almost like it's basically like they don't exist. And then you can't use those codes for the usual billing purposes as they're used all over the United States.
I appreciate that, Doctor. Thank you so much.
Chair,
problem.
Chair.
Vice Chair, if I may, Kristen Pendergrass has a response as well, if she's allowed to speak.
Yes, please go ahead. Thank you.
Thank you, Mr. Vice Chair and Assemblywoman Taylor. My name is Kristen Pendergrass. I'm the Vice President of State Policy for Shatterproof. We're a national nonprofit that is working with states to get Medicaid to cover these codes around the country. And I just wanted to let you know there are 22 states that currently cover the codes for collaborative care model in their Medicaid programs. And there are a lot of private insurers that do so as well.
Thank you. Other members of the committee? Assemblywoman Nguyen?
Thank you, Mr. Vice Chair. I think I wasn't going to have a question, then Chair Peter said something that kind of triggers something in my head. In this collaborative care environment, I know that we trying to put in a lot of different partners all around just to ensure that the patient is taken care of. Is the model has any types of involvement from the school district? Since you mentioned something about, having diagnosed and then they can go back to the school setting in a accommodated environment. Is the model including the school setting just because that's a major part of the child's life? So that's just my question. Thank you.
Thank you,
Thank you
Assembly.
for the question. I'll take this one. It's Dr. Lisa Durrett for the record. As the child psychiatrist, I figure I should take this one. Other states do have models for child psychiatry access programs that will directly help in schools where the child psychiatry team can interface directly with school counselors, school nurses, school administration. Again, with funding, we'd be able to expand the program statewide to do such a thing. And so this is what's interesting. We fully support this bill, and I think it's going to have an enormous reach statewide. The type of program that we do is similar, but a little bit different in that the cost is for the program itself, which is not just the psychiatry services, but the care coordination, the infrastructure, the back of house. And so with additional funding, you would be able to expand us into the Palin Schools model or the Pediatric Access Line in Schools model.
Thank you. Other questions? Assemblywoman Thomas?
Thank you, Mr. Vice Chair. Great presentation, and it triggered something in my mind also. Would this help, I think it's a 504 for children when they're in school and they need to be able to go to a psychiatrist for, I believe Chair Peters said that her daughter just needs a quiet space for taking tests, and this would help with other students that may have some learning challenges. And I'm not sure if I'm thinking of that number 504 or 507. I don't know. It's a 504? Okay, all right. So, will it mean that you won't have to go to a psychiatrist? Your primary doctor could recommend the 504? Am I understanding it correctly?
Excellent question. This is Dr. Lisa Durrett for the record. So the 504 plan, and you were correct, it was 504, as well as individualized educational plans, IEP, fall under the Individuals with Disability Education Act of 1974 and are federally protected resources for kids, for which a doctor's order, a doctor's recommendation actually is not needed. And I think that that's an unfortunate misconception in the world of education, and unfortunately gets leveraged inappropriately. The whole role of our program is to initiate or to help support primary care clinicians' ability to initiate treatment. So for example, we will talk through with the pediatrician how to start a medicine for ADHD, how to start a medicine for anxiety. We will give recommendations for types of psychotherapies that could be helpful for a child struggling with depression, struggling with anxiety. And our care coordinators provide education to the families in both English and Spanish, as well as help connect them and provide a warm handoff into the community. And so those are the very specific services that a program like ours is able to provide. I hope that answers your question.
Follow-up, Chair? Vice Chair, sorry.
Yes.
Thank you so much. That cleared up the cobwebs in my head. Thank you so much for that.
Thank you, Assemblywoman Newby.
Thank you, Mr. Vice Chair. In AB 138, the requirement that the state pay the non-federal share for Medicaid. So I'm assuming that that means that these rates are already set somewhere and we're just including that in our plan for Medicaid. Is that essentially what we're doing here?
Leah Case for the record, through you, Vice Chair, to Assemblywoman Newby. That is correct. I do believe that Kristen Pendergrass from Shatterproof has more information, and we can provide you with a handout on those codes and rates that have been used at the national level and adopted by other states.
Thank you, Mr. Vice Chair and Assemblywoman Newby. My understanding is that most states start with a percentage of the Medicare rate. These codes have been covered by Medicare. CMS approved them a couple years ago, I think in 2018. And so most states start with a reimbursement rate that is somewhere around 85% of Medicare. But as we all know, with the behavioral health crisis that this country is dealing with, other states have made it equal with Medicare, and some are even looking at increasing it beyond Medicare levels.
Okay, thank you for the questions and responses. I think we can now move on to testimony and support, opposition, and neutral. Please remember to clearly state and spell your name and limit your testimony to 2 minutes. Mr. Ashton here is a rigorous timer and will keep us posted. Staff will, and we'll want to make sure everybody has a fair opportunity to speak. We'll begin testimony in support of AB 138. First from those present here in Carson City, and then move on to testimony from Las Vegas, and then people calling in. So please approach and state your name and spell your name and proceed.
Good afternoon, Mr. Vice Chair and members of the committee. My name is Jeanette Beltz. I am here today representing the Nevada Psychiatric Association as well as the Nevada Public Health Association in support of this bill. I think there was a point brought up earlier about leveraging psychiatric services. I really see this kind of as extending them so that they're available and access is available. Whereas there are a number of barriers that, as were testified to, in terms of connecting people to those services and really being able to do it through the primary care setting, which is where more patients are more likely to initially come in contact. So it really provides greater access to these services, and with what we're dealing with in our state. I also wanted to mention that this is not just restricted to moms, pregnant moms at high-risk pregnancy center or children through the educational system. This is regardless of age. So thank you so much.
Thank you. And next.
Good afternoon, Chair Peters and members of the committee. My name is Nicole Winkleman. It's a long last name, so Winklemann. I am the policy intern for the Nevada Coalition to End Domestic and Sexual Violence, here today in support of AB 138 and hoping to provide a violence prevention perspective within the issues covered today. Access to mental health care is necessary for violence prevention and intervention, yet unfortunately for so many Nevadans, access to mental health care is challenging or worse, unobtainable. After an incident of intimate partner violence, victim survivors are at a heightened risk of PTSD, substance abuse, and mental illnesses, and such as depression and anxiety, and these risks are heightened even further for pregnant and postpartum victim survivors and their children. Additionally, perpetrators often target those with untreated mental illnesses because of their vulnerability and likely previous victimization. Repeat victimization and untreated mental health symptoms keep victim survivors from adequately functioning in society, making it challenging to maintain employment, parent their child to the best of their ability, attend schools as students, and as such have detrimental effects. Mental health interventions are necessary to address and reduce violence in our communities, and so expanding Medicaid is an important step in creating mental health access and violence prevention. Thank you.
Thank you, Ms. Winkleman. Our next testimony.
It's operator dependent. I'm Dr. Barry Cole. I've been a psychiatrist in this state since 1986. I'm in support of this. I attended national training through the American Psychiatric Association in October in Minnesota. This is being kind of promoted throughout the United States, and it may actually solve a problem that will occur when the public health emergency ends on May 11th, that we'll be able to extend mental health providers. So you're not just looking at this in Nevada, as you've heard it's in other states. We think this is a viable model that allows psychiatrists to collaborate with their primary care provider colleagues and have mental health support staff working directly with those people, and then the psychiatrists would be giving advice and answering questions. There's just not enough of us to go around, and if you see this white hair, it's for real. I didn't dye my hair. I am retired, and I'm exiting my career in medicine after 42 years, and there's just not enough people coming into psychiatry, although God bless Nevada, we got 20 graduates every year coming out of our 3 psychiatric residencies. My one concern is 75% of them are leaving for California, Utah, and Idaho, so that means a net gain of 5. So anything we can do to extend mental health is a net win for us. Thanks.
Thank you for your testimony. Anybody else here would like to testify in support? Okay, it looks like we have some people wanting to testify in Las Vegas, so let's go to you all.
Thank you very much, Vice Chair Ornlicker. My name is Leanne McAllister, Leann, I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics, and we are in support of AB 138. The American Academy of Pediatrics strongly encourages collaboration between pediatricians and mental health specialists to determine the best course of treatment of patients. Mental health is an essential component of overall health. Mental health challenges, from individual symptoms to diagnosed mental illness, impact all children, adolescents, and families. The American Academy of Pediatrics supports a developmental approach to children's mental health that encompasses primary prevention through promoting social emotional health and safety and nurturing relationships, secondary prevention through screening, identification, and assessment, and tertiary prevention through treatment and co-management with mental health professionals. The Nevada AAP looks to Medicaid to reduce the administrative and financial barriers to access care and allow collaboration. Thank you.
Thank you, Ms. McAllister. You've got a colleague there who would like to testify.
Yes, thank you, Vice Chair and members of the committee. My name is Dr. Amanda Habush-Deloye. That's Habush-Deloye, and I am the Executive Director for the Nevada Institute for Children's Research and Policy, although I am here today representing myself as well as the Clark County Children's Mental Health Consortium, which I currently serve as chair. Our 10-year annual report has shown that we have severe lack of services for mental and behavioral health for our children and our families. And one of our goals in our plan is to increase access to a spectrum of different services. And we do believe that increasing this coordination and ability for reimbursement will serve that purpose to help to increase access care for individuals. We've also experienced firsthand through parent stories as well as stories from myself and colleagues in our office who, even though it's not our job, we firsthand see the benefits when families are able to be directly connected to the services they need through either their primary care physician or just a warm handoff without just providing a referral slip to another service. This also coordination between primary care and mental and behavioral health services helps to reduce the stigma and prejudice against mental health in our community. So this will serve another purpose to move that forward. Thank you.
Thank you very much. Is there anybody else in Las Vegas who would like to testify in support of Assembly Bill 138? Okay. BPS, can we move to the callers in support?
If you would like to testify in support of Assembly Bill 138, please press star 9 now to take your place in the queue.
Good afternoon, Vice Chair Orentlicker, members of the committee. For the record, my name is Katie Ryan, K-A-T-I-E-R-Y-A-N, and I'm the System Director of Nevada Government Relations for Dignity Health St. Rose Dominican. St. Rose is here today in support of AB 138, which will require Nevada Medicaid to cover collaborative care medical models that include behavioral health and substance abuse disorder treatment. Medical care should treat the entire patient, both physical and mental, and this is a great step towards clinics and health systems having the ability to bill for all services. AB 138 will also make for better outcomes for pregnant women and their babies, along with better mental health services for children and all patients, quite frankly. I wanted to bring to your attention a piece on 60 Minutes that aired last May that discussed an innovative behavioral health model for children in Wisconsin that uses a collaborative care model within pediatricians' offices, emergency departments, and behavioral health clinics. I can send the link around to the committee members that you can watch, as it clearly describes how this will be able to help just one subset of our patients. Thank you.
Thank you, Ms. Ryan. Next caller, BPS, please.
Hi, this is Dr. Deepa Nagar. Can you guys hear me?
Yes, thank you.
My name is Dr. Deepa Nagar, spelled D-E-E-P-A, last name N-A-G-A-R. I am a neonatologist and medical director of the Neonatal Intensive Care Unit at St. Rose Sienna Hospital in Henderson, Nevada. I'm also the chair of pediatrics. I'm a pediatrics affiliated physician. Our group covers pediatric care in pediatric intensive care unit, pediatric ER patients, along with the neonatal intensive care unit across Nevada and the country. As you guys know, there's unprecedented number of children with suicide attempts, and overdoses in the last few years, and Nevada, unfortunately, is one of the highest. We absolutely need support for our patients. And as a direct physician who takes care of patients, I was involved in the and the Empowered program as a co-founder. When we started this program, there was a decrease in withdrawal incidents. In 2017, we had approximately 40% of our NICU filled with babies who had, unfortunately, neonatal abstinence syndrome. In collaboration with the Empowered and Mother program, there has been a significant decrease in the overall admissions to the NICU for this significant problems. We are now currently less than 10% of our infants admitted to the NICU for this. This is a direct impact when a clear, good, concise way of collaborating shows the impact. And I cannot support this measure more.
Thank you, Dr. Nagar. Do we have next caller on BPS, please?
Good afternoon, Vice Chair and Madam Chair Peters. My name is Dora Martinez, DORA-MARTINEZ, and I represent the Nevada Disability Peer Action Coalition. We are people with various disability, and we thank you so very much from the bottom of our heart, Assemblywoman Peters. This is what we need, especially people with disabilities, so that way it's a one-stop shop. I don't know if you are all aware, some people like myself who are blind and cannot legally drive, it's hard to get from one appointment to another to the next and scheduling all appointments with transportation and doctors. So our group, my coalition absolutely support this, and we're behind you 100%. Thank you so much for your valuable time. Take care.
Thank you, Ms. Martinez. Next caller, please.
Vice Chair, the public line is open and working. There are no other callers to participate at this time.
Thank you, BPS. Let's move now to opposition testimony. Anybody in Las Vegas, if you want to testify in opposition, please approach. Okay. Did I say Carson City? Sorry. Carson City. Okay. And then I guess we did Las Vegas. Anybody online in opposition?
The public line is open and working. There are no other callers to participate at this time.
Thank you. Let's now move to neutral testimony in Carson City. If you want to testify in neutral, please approach. Okay, Las Vegas. Anybody who wants to testify in neutral in Las Vegas? Okay. Callers, BPS. Anybody calling in neutral?
There are no callers to provide neutral testimony at this time.
Excellent. Any final remarks, Chair Peters?
Thank you, Vice Chair Sarah Peters. For the record, I just want to express my thanks for Ms. Bell's bringing up the expanded communities and patients. Of course, in my own life, I am hyper-focused on my health and my children's health, but she is absolutely correct that this collaborative care model expands to all demographics who search out healthcare and who need collaborative care, regardless of where they are, especially those who are on Medicaid. I told you all at the beginning of this session that my goal is to reduce barriers, expand access, increase treatment and continuity of care, and increase transparency. And I believe that this bill covers all of those issue areas. With that, I thank you for your time today and for hearing this bill, and we hope that we have earned your support.
Thank you very much for bringing this bill, and we welcome you back. And this closes the hearing on Assembly Bill 138.
All right, thank you for taking over, Vice Chair. Appreciate the opportunity to present our first bill in committee. That was a joy. It's been a minute, like riding a bike, y'all. We're going to go ahead and move on to our next bill hearing and open up the hearing for AB Assembly Bill 114. I will go ahead and let our folks get themselves situated at the table and we can begin. Assemblywoman Thomas, thank you so much for being here today. This bill revises provisions governing the Nevada Early Childhood Advisory Council. Please begin when you are ready.
Thank you, Madam Chair. And good afternoon, Chair Peters, Vice Chair Ornlicker, and committee members. For the record, I am Assemblywoman Claire Thomas, representing Assembly District 17. It is my pleasure to present to you Assembly Bill 114 concerning the Nevada Early Childhood Advisory Council. Joining me today is Patty Oya, Director of the Office of Early Learning and Development at Nevada's Department of Education, and Denise Tanata, Chair of the Nevada Early Childhood Advisory Council. They're both in Las Vegas. Before I begin, I would like to point out two exhibits which are both available on Nellis. First, you will find a presentation on the council and the bill overview. And second, there is an amendment I am proposing to AB 114. I would like to talk about the importance of early childhood development and the Nevada Early Childhood Advisory Council. Early childhood development refers to the period of growth and learning that occurs in children from birth to age 8. This is a crucial time in a child's life as it lays the foundation for their physical, emotional, social, and cognitive development. Research has shown that early childhood experiences have a significant impact on a child's future outcomes, such as academic success, health, and economic stability. In fact, the first 5 years of a child's life are critical for brain development, with 90% of a child's brain growth occurring during this time. That's why it's so important that we invest in early childhood development. We need to ensure that children have access to high-quality early learning experiences that promote their development and prepare them for success in school and beyond. For instance, growing research consensus shows that high-quality preschool programs prepare children better for school, especially in terms of academic skill development. Research also shows that modifiable factors in a child's early years can greatly affect the child's health and learning trajectories. We need to support families and caregivers to help them provide a nurturing and stimulating environment for young children. This is where the Nevada Early Childhood Advisory Council comes in. The council is a group of experts from across the state who provide guidance and support to improve the quality of early childhood programs and services in Nevada. Their mission is to promote a comprehensive, high-quality, and coordinated system of early childhood services that support the development of young children and their families throughout Nevada. The council works to strengthen state-level coordination and collaboration that support early childhood development, such as increasing access to high-quality early learning programs, supporting the professional development of early childhood educators, and advocating for policies that promote family-friendly workplaces and support for working parents. Now I will hand over to my two co-presenters who will provide you with more details on the council and an overview of Assembly Bill 114.
Thank you, Assemblywoman Thomas. For the record, my name is Denise Tanata. My last name is T-A-N-A-T-A. I currently serve as the chair of the Nevada Early Childhood Advisory Council. I also serve as the Early Childhood Comprehensive Systems Director at the Children's Cabinet. So we're going to walk you through really two pieces. One, just a little bit of detail on the Nevada Early Childhood Advisory Council, going over the history, purpose, and current membership, and then I will pass over the presentation to Patty Oya, who will walk through the provisions of AB 114. So just a brief history on the Nevada Early Childhood Advisory Council. Most states have an early childhood advisory council of some sort that was required through the federal Head Start Act in 2007. In 2009, our state early childhood advisory council was created by executive order, and that executive order was continued in 2011. And then in 2013, the Nevada Early Childhood Advisory Council was established in NRS through NRS 432A.076 and has undergone a couple revisions since that time. I won't restate the vision and purpose, Assemblywoman Thomas went over that, but just wanted to reemphasize that the purpose of the Early Childhood Advisory Council is really to serve as an advisory body looking at the early childhood system in the state of Nevada, really focusing on safety, healthy development, and really with an outcome of ensuring that children have an opportunity to thrive during those first years of life. This slide depicts the current membership roles that are outlined in the NRS for the Nevada Early Childhood Advisory Council. I won't go through each one of these individually, but we do have currently 20 members, 20 positions on the Early Childhood Advisory Council. As of right now, we only have one vacant seat on the council. 12 of those members are specified based on their roles in NRS 432A.076. 8 of the current members of the Early Childhood Advisory Council sit in seat M, which is other members as the governor deems appropriate to serve on the council. In the end of 2021, the Early Childhood Advisory Council underwent a strategic planning session to develop our 2022-2024 strategic plan. A lot of that emphasis was around creating a comprehensive early childhood system. What we recognized is that the early childhood period involves more than just early childhood education. We really wanted to make sure that we were including a focus on health, protection, mental health, as well as early learning supports. On November, so we created the 2022-2024 strategic plan, which is focused away from just looking at programmatic supports, but really looking at how we can improve our early childhood comprehensive system in the state of Nevada to be inclusive and take a holistic view of children and their families. On November 30th of 2022, the Nevada Early Childhood Advisory Council approved recommended changes to the membership and the role of the Early Childhood Advisory Council to be able to expand membership to be inclusive of that holistic approach to early childhood. And those recommendations were included in our annual report, which was submitted to the governor's office as well as to this body on December 1st of 2022. So at this point, I'd like to hand it over to Patty to talk about the bill.
Good afternoon, Chair Peters and committee members. My name is Patty Oya, O-Y-A. I'm currently the Director of the Office of Early Learning and Development for the Department of Education, and I will just be going over the summary of what this bill, the changes in this bill. Throughout the NRS 432A.076, we're suggesting the changes from education to early childhood program. So this aligns with the systems work that is being done across the state, because we know early childhood is more than just the educational piece of development. It should also include health and family leadership and support. So this change encompasses that thinking. We also are suggesting 5 members be added to this, again, to align with early childhood systems work. And this includes the Department of Behavioral Health, Maternal and Child Adolescent, a public school member serving children in K through 3rd grade, a tribal organization. We have been working closely with tribes across the state of Nevada to include them in the early childhood system, and a program for child care and development, which is our child care and development funds under the Division of Welfare and Supportive Services, as well as a parent or guardian of young children. And currently, I think that's the most important piece, because we want to have the parent voice at the table. Again, another change is to add the definition of early childhood program. Assemblywoman Thomas gave you that definition, and it is here on the slide. It is really true to look at the age from 0 to 8, and so, and looking at that holistic approach. The few proposed amendments that we would like to see changed as well are some small language change. Under 1.1E, under the membership, the way it currently reads, it says Department of Education, the person, the program's under Section 619 or Part C, and that makes it sound like both of those roles are under the Department of Education, when actually the Part C office is under the Department of Health and Human Services. So while it's still an or, we want to make sure it's very clear that one role is under the Department of Education and one role is under the Department of Health and Human Services. In 1.1Q5, it reads Special Supplemental Nutrition Program. It really should read Supplemental Nutrition Assistance Program, otherwise known as SNAP. And then the last change in 1.5, the early childhood program definition, this is a small change. It bullets out the components, but really it should read as a sentence, because all of those things, nutrition, health care, mental or behavioral health, protection of or play and learning, all of those things stimulate physical, cognitive, linguistic, social, and emotional development. The fiscal note that has been included in this is that while this might look unusual that it is $0 for the fiscal year 24, 25, and 26, that's because as the responsibilities and the membership of the Early Childhood Advisory Council grows, it is recommended that 2 positions are needed to support the council's work, and one of those is an education programs professional, and one would be an administrative assistant. And both of those are currently written into a federal preschool development birth to 5 grant that the Department of Education received at the beginning of the year. And so that is why there's a $0 fiscal note, but it's important to note that those positions are needed. The grant is a 3-year grant, so we'll end in fiscal year 26. At that time in fiscal 27, we do have the fiscal note, but we weren't sure if that's, if this was needed at this time, but we wanted to be clear that we do have the federal funding to support these positions. And we're obviously here to answer any questions, but you also have our contact information if any follow-up information is needed. Thank you.
Thank you so much. At the end of the presentations, we can move on to questions. I have a few questions from committee members. I'm going to go ahead and start with Assemblyman Nguyen.
Thank you, Madam Chair. Thank you, Assemblywoman Thomas, Ms. Tanada, Ms. Oya, for a great presentation. I'm really heartening to hear that we are diversifying and adding more voices to the table and making sure that these programs are really well thought out. I just thought about two of the members that you're planning to add. Were there any thoughts that maybe there are in discussion about, as we're talking about reducing barrier and creating more access? The two roles that I'm most concerned about or wanting to see if there's thoughts behind adding is the nonprofit role and the parent role. Are there any consideration of adding perhaps either a member within those two roles or maybe a new member that come from household with bilingual? Because one of the things that is important, for early child programs, as a parent of a bilingual household, a lot of these sometimes these programs really think of us as an afterthought. And I want to make sure that we can get ahead of that and ensuring that the bilingual household are at the table. So if anyone could help me clarify that, that would be great. Thank you.
Thank you. This is Denise Tanada for the record. We definitely appreciate that recommendation. I think it was our thought that under the parent role, actually the reason we didn't just state one is we wanted to have the opportunity to have more than one parent and not set a specific limit on that so that we could have diversity, particularly among our parent representatives serving on the council. We definitely would be open to including some language to ensure representation from a bilingual household, though.
Great. I appreciate that. Thank you so much. Thank you, Chair.
Thank you for the question. I have Assemblyman Hafen next.
Thank you, Madam Chair, and I appreciate the presentation today. Just one question. You stated that you have one vacancy, but I see we're proposing to add additionals, and I think the additions will be good to the council. But I want to ensure that we'll be able to fill those spots, and there'll be adequate representation. I know in rural parts of Nevada, we struggle when we limit the roles that have to be filled and trying to find those individuals that are willing to volunteer their time to do the work. So I just want to make sure that we're not going to set it up for failure and that this will be successful.
Thank you, Denise Tanada, for the record. I echo your sentiments. As the chair of the Early Childhood Advisory Council, I can tell you that there have been a council that is required to follow open meeting law. Quorum is definitely something that we keep a close eye on. We're very excited right now that we are at almost full membership of having our members appointed. The ability to fill these slots was a big part of the conversation that we had when we were putting these recommendations together. So I do want to note that for the representative from the Division of Public and Behavioral Health that's currently not represented, but they are a partner and do participate in our Early Childhood Advisory Council. So we don't anticipate that being an issue to fill that seat and having them participate. For the member the new position that would be from the Child Care Program for Child Care and Development, that would be a transfer from seat M, which is those other members as appointed by the governor, into that role. Also, the new slot for a member who is a representative of public school would also be a transfer from seat M, which is other members as appointed by the governor. So we have individuals who are filling those roles right now. They're just not specified in statute. And then we also have one member who's a representative of a tribal organization. I just wanted to note, we have local early childhood advisory councils that participate in our state early childhood advisory council. One of those is the tribal Early Childhood Advisory Council, which is overseen by the Intertribal Council of Nevada. So we anticipate that that will be able to fill that seat and that they will participate. They participate in our regular meetings. And then for the parent and guardian piece, we actually have several places to pull from right now. One is the newly established Nevada Early Childhood Family Leadership Council, where we're working with family leaders who have lived experience in early childhood systems to be able to support them and provide them with training experience to serve in leadership and decision-making roles. And then also through our partner at the Children's Advocacy Alliance, they have the Child Advocacy Ambassador Program and have several parents who are interested in serving in leadership and decision-making roles in the state.
Thank you. I'm very happy to hear that you guys have already thought about this and run through the struggles and made sure to address them all. So that makes me very happy to hear. So thank you. And thank you, Madam Chair.
That is an impressive list of folks who are interested in this issue area, but it does touch quite a few areas of interest. I had a quick follow-up on that question, and it has to do with any of your representatives potentially filling up two of those member roles. Do you ever have that happen, or is it always just one member filling the single role?
This is Denise Tanada for the record. I was just looking at Ms. Oya. Can we think of a time when we've had, I think the only, in response to your question, I can look into it to see if it's been an issue in the past. The only thing that we've seen right now is with those other members as assigned, we have had some individuals who could have potentially filled one of the designated roles, but were put into the other member category. But from my recollection right now, that's the only overlap that we've had.
Okay, thank you so much. Assemblywoman Gorlow, have you next?
Thank you, Chair Peters, and thank you for being here. I'm really glad to see that there is that parent voice and that you will take more than one parent if more than one is interested in fulfilling a role, because so many of those parents fill a variety of roles when their experiences. But I just kind of had a question, if we could elaborate a little bit more on what the federal and state early childhood programs are. We list 5, but can you elaborate a little bit more on what those programs are? Would like early intervention services count, or the nurse family partnership?
Denise Tanada for the record, and thank you for the question. These are the federal state early childhood programs listed are including but without limitation. So we're not trying to limit to just participation. I think what we were hoping to demonstrate in this provision is that we wanted to make sure that we were including parents that have lived experience with an early childhood program, that they could bring that experience, whether it's with child care subsidy program, Head Start, early Head Start, home visiting, or early intervention or other programs. So looking at that holistic view of family and needs, that they would be able to bring that experience to the table and to help make decisions. But it's not meant to be an exhaustive list, if that addresses, I think, your question.
That does. Thank you very much for that clarification, and good to see you as always.
Thank you so much for the question. Assemblywoman Taylor, have you next?
Thank you, Chair. And thank you, Assemblywoman Thomas, for bringing this forward. Early childhood education, that's where it begins. Count graduation rate, but that's the end. So I appreciate the early effort. My question is about the federal grant that will cover for the first few years of this grant. Is there any possibility, and it may be for your co-presenters, any possibility that grant might get extended, or we could reapply or anything like that?
For the record, Patty Oya, Department of Education. It is possible this is a continuation of a grant that Nevada received a few years ago called the Federal Preschool Development Grant Planning Grant, and then this is the implementation piece of, it's a 3-year grant. But from what we understand, so different states are in different cycles of those grants planning and implementation. And from what we've heard, they are planning on continuing implementation grants, which would be great. We also have the Child Care and Development Quality dollars as another federal source from the Welfare Division to the Department of Ed that we could also use down the road. But this is the first time we've really addressed the positions needed to support the council.
Okay, thank you very much. Thank you, Chair.
Thank you.
Thank you for the question. Are there other questions from members? Seeing none, we will go ahead and move on to testimony in support, opposition, and neutral of Assembly Bill 114. Please remember to clearly state and spell your name and limit your testimony to 2 minutes. Staff will be timing each speaker to ensure everyone has a fair opportunity to speak. We will begin testimony in support of AB 114. We will hear first testimony from those in the physical locations and then move to testimony from anyone who has called in. Is there anyone we have a couple folks in Carson City, a couple folks in Las Vegas. We're going to go ahead and start here in Carson City. Please remember to state and spell your name for the record. You have 2 minutes.
For the record, this is Zoe Houghton, ZoeHoughton, with Tom Clark Solutions, here on behalf of the Children's Cabinet in support of AB 114. Since 1985, the Children's Cabinet mission has been to keep children safe and families together by providing services and resources that address unmet needs through a unique and effective cooperative effort between private sector and public agencies in Nevada. There is no wrong door, and the Children's Cabinet ensures those who need services are provided services at no charge. Today, the Cabinet serves more than 11,000 Nevada families each year from 6 locations throughout the state, in Reno, Carson City, Las Vegas, and Elko. We appreciate the sponsor for bringing this bill, and we are in full support. Thank you.
Thank you. Please, next.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. My name is Zach Bucher. That's Z-A-C with an H, no K. Last name Bucher, B like boy, U-C-H-E-R. I'm with the City of Las Vegas. As a provider of early childhood education, the City of Las Vegas supports AB 114 for expanding the membership of the Advisory Council to include representation and input from agencies and individuals that are closest to the population this council aims to serve. This bill also gives parents and educators working in early childhood a voice and seat at the table. And finally, given the current challenges and incidents with children and youth behavioral health, it is critical that input and membership is given to behavioral and public health agencies. We'd like to thank the bill sponsor for bringing this bill forward and offer our support. Thank you, Madam Chair.
Thank you so much. Is there anyone else in Carson City who would like to provide public testimony? All right, we will go ahead and move to Las Vegas location. Please remember to say and spell your name for the record. You may begin.
Good afternoon, Chair Peters, Vice Chair Ornlicker, and esteemed members of the Health and Human Services Committee. My name is Jamelle Nance, that is Jamelle-Nance. I'm the Director of Prenatal to 3 Initiatives with the Children's Advocacy Alliance. I would like to share my support of Assembly Bill 114 to revise the provisions governing the Nevada Early Childhood Advisory Council. Current provisions primarily focus on early childhood education programs, and as an attendee of the Early Childhood Advisory Council, I can attest that it is heavily represented in the area of education. There is a need to expand membership to reflect the entire systems of care that impact young children and families. In my previous work as a coordinator of family services and a home visitor for families with children birth through age 5, I was able to experience firsthand the impact of that cross-sector coordination. And so it really truly takes a team to see families thrive. This means that leaders in healthcare, mental health, and the workforce, as well as parents and caregivers, must have a seat at the table. Section G of the current provisions outlines that the role of the Nevada Early Childhood Advisory Council is to develop recommendations for increasing parental involvement and family engagement in early childhood education programs. To make such recommendations, it's imperative to have parents be fully involved. The Nevada Early Childhood Advisory Council plays an important role in convening and providing recommendations to strengthen state-level coordination and collaboration in the early childhood programs. This cannot be adequately done without true representation of the systems that directly touch the lives of our children. So today we're asking your support of the revisions proposed in Assembly Bill 114. Thank you for your time and consideration.
Thank you so much for your testimony. We have one more person at the table in Las Vegas. Please go ahead when you're ready.
Hello, Chair Peters and members of the committee. My name is Dr. Amanda Habush-Deloye. That's Habush-Deloye, and I'm the Executive Director for the Nevada Institute for Children's Research and Policy, and we also house the Southern Nevada Early Childhood Advisory Council. However, today I am representing myself and not my job. So as part of that community, though, I have been involved with the Nevada Council since its inception. And while in practice, we recognize that it takes a holistic approach when looking at early childhood, and that those children and families live within a system that addresses health, family engagement, education, as well as other forms of the committee. We also have deep discussions around diversity, inclusion, and equity, and I feel like these changes to the proposed membership help to solidify and address some of those discussions that we have to make it a formal process to make sure that we have full representation on the committee. Therefore, urge you to support AB 114. Thank you.
Thank you so much for the testimony. Is there anyone else in Las Vegas who would like to provide public testimony in support of AB 114? Seeing none, I would ask BPS to please add the first caller to the meeting in support of Assembly Bill 114.
Callers, if you would like to testify in support of Assembly Bill 114, please press star 9 now to take your place in the queue. Callers, if you would like to testify in support of Assembly Bill 114, please press star 9 now to take your place in the queue. Chair, the line is open and working. There are no callers choosing to participate at this time.
Thank you so much. We're going to go ahead and move into opposition testimony of AB 114. Is there anyone in Carson City who would like to testify in opposition to Assembly Bill 114? Seeing none, are there anyone in Las Vegas who would like to testify in opposition of Assembly Bill 114? Seeing no one moving up to the table, BPS, would you please add the first caller for opposition to Assembly Bill 114?
Callers, if you would like to testify in opposition to Assembly Bill 114, please press star 9 now to take your place in the queue. Chair, there are no callers choosing to participate at this time.
Thank you so much. We're going to go ahead and move into neutral testimony. Is there anyone in Carson City who would like to testify in the neutral position for Assembly Bill 114? Seeing none, is there anybody in Las Vegas who would like to testify in neutral on Assembly Bill 114? Seeing no one move up to the table, BPS, is there anybody on the line who would like to testify in neutral on Assembly Bill 114?
Callers, if you would like to testify in neutral for Assembly Bill 114, please press star 9 now to take your place in the queue. Chair, there are no callers choosing to participate at this time.
Thank you so much. Would this bill sponsor like to make any closing remarks?
Thank you, Chair, and thank you to the committee members for listening. AB 114 ensures that the Council's critical work continues so that all children in Nevada have the opportunity to reach their full potential. By investing in early childhood development and supporting the work of the Nevada Early Childhood Advisory Council, we can ensure that our youngest children have the best possible start in life and are prepared to succeed in school and beyond. It is our hope that you will support AB 114. Thank you.
Thank you, Assemblywoman. Thank you so much for your time in presenting today. We're grateful that you are here. I'm going to go ahead and give us a moment for Assemblywoman Thomas to rejoin us up at the dais. In the meantime, I'm going to close out the hearing on Assembly Bill 114 and move on to our next agenda item. We have a bill BDR introduction, committee BDR introduction. Today we have Committee BDR 297. This BDR establishes a program to provide structured family caregiving to certain recipients of Medicaid. Again, this is a committee BDR. And your vote to move this to be introduced on the floor does not commit you at all to this potential bill. I would go ahead and entertain a motion to...
So moved.
Thank you. I have a motion from Assemblyman Orntlicker and a second from Assemblywoman Gorlow to introduce BDR 297. Is there any discussion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed? The motion passes unanimously, and that bill will make its way down to the floor. Fantastic. I think that is our last order of business before moving on to public comment. Fantastic. We're going to go ahead and open public comment. I'm going to go over a couple of things while we get the public comment line going. We ask that public comment be kept to 2 minutes. Please avoid repetition of comments made by previous speakers. We all love a good ditto. Staff will be timing each speaker during public comment to ensure everyone is given a fair opportunity to speak. Please clearly state and spell your name for the record, and then we will start your time. We will begin with public comment from those in the physical locations, and then move to public comment from anyone who is calling in. This gives our public comment line plenty of time for folks to call in if they would like to. Is there anyone in Carson City who would like to provide public comment at this time? There's nobody coming up to the desk. Is there anyone in Las Vegas who would like to provide public comment today? Seeing no one move up to the desk, go ahead and ask BPS staff if there is any callers on the public comment line who would like to provide public comment today.
Callers, if you would like to provide public comment, please press star 9 to take your place in the queue. Callers, if you would like to provide public comment, please press star 9 now to take your place in the queue. Chair, the line is open and working. There appears to be no callers choosing to participate at this time.
Thank you so much, BPS. We're going to go ahead and close that item on the agenda and move on to any comments, final comments from folks on the committee. Seeing none, that concludes our meeting for today. Our next meeting will be Wednesday, February 22nd at 1:30 p.m. And with that, our meeting is adjourned.